It's Dr. Kyle Chapple, Neurosurgery, here to talk today about the cerebral vascular suite that we're currently in right now. You can see the screens and the X-ray imaging cameras, both from the anterior and the lateral simultaneous imaging. And what are we doing here? So there's several things that we can treat from an endovascular perspective here in the Angio Suite. Endovascular just means from the inside of the blood vessel. We can treat ruptured aneurysms or aneurysms electively. We can treat arteriovenous malformations in the brain, which is some problems with the arteries and the veins as they communicate with each other inside of the brain. We can treat acute ischemic strokes, which is it's a stroke where you may think of a patient having weakness on one side of their face, difficulty speaking, weakness in the arms or legs. That's the kind of stroke which, within a timely fashion, we can bring patients in emergently, go in with different instruments and catheters that we have here, and reopen the blood vessels in the brain and stop the stroke from occurring. And other things we can also treat is stenosis of the carotid arteries or arteries around both intracranially and in the neck by either going in with catheters and inflating a balloon to re-expand those arteries and then placing a stent inside of those arteries to keep them open. One of the greatest benefits of being able to treat blood vessels and problems with the blood vessels of the brain from the inside is it's essentially as minimally invasive as you can get. The access point is either in the wrist or in the top of the leg through a small pinprick in the artery, and then we guide our catheters up into the brain. And through that small access point, we can treat all of very many different problems with the blood vessels of the brain. Prior to this discipline's development, the only way to treat those problems with the blood vessel would be from the outside, making an incision in the skin, window in the bone, and going down through the brain to try to fix whatever problems with the blood vessels that were occurring. But now, because of the advent of this technology and the instruments and catheters and the other things that we get to use here, we can treat a lot of these problems from the inside from a minimally invasive approach, which helps patients heal faster and does less damage to the brain overall. In talking about an AVM, or an arterial venous malformation, it's a malformation of the arteries and the veins within the brain, and it's a problem with the communication between the two. The high flow artery, that pressure flows right into the low flow veins, and it creates a very high velocity of blood flow through that abnormal structure in the brain, and that can cause strokes and can also cause rupture and bleeding within the brain. So to treat that, we do two things. We come here to the Angio Suite, we do a cerebral angiogram, we learn about the blood flow to the AVM, the blood flow in and the blood flow away. We look and see if there's any aneurysms or other flow-related problems associated with that AVM, and we start to develop a treatment plan. It usually involves shutting down some of the arterial flow from the arterial side during an angiogram, and then it may also involve going to the operating room and doing an open procedure where we dissect through the skull down into the brain, find out where this malformation is, and remove it, and thereby curing the patient. And there's also another aspect of treating AVMs where it may take a little bit of endovascular, it could take a little bit of going to the operating room, and there's also using stereotactic radiosurgery, which is focused beams of radiation to further and completely treat the AVM. All of these aspects are possible, and the kind of the three ways that we use some kind of combination of them to treat an AVM. But it usually and always starts here in the Angio Suite doing an angiogram, where we initially learn about the blood flow in and out of the AVM. A cerebral angiogram does not hurt. It's one of those tests that can be done with patients awake under a minimal amount of sedation. If we're just taking diagnostic pictures of the blood vessels of the head and neck, patients can be awake. We bring them in, we can do the angiogram, take the pictures. There's no pain. They may feel a little warmth as the contrast washes through with the blood flow both in and then out. And it takes a matter of 15-20 minutes, sometimes even faster, to take those pictures. Now, if we go on to do an intervention, meaning we go on to do some work on the blood vessels, patients, we generally put them asleep, and it may take longer. It can take hours. So if we're doing a diagnostic angiogram and we just want to look at the blood vessels, learn about them, see if there's any pathology associated with the blood vessels of the head or neck, we can do a cerebral angiogram with the patients awake, and it's not uncomfortable. They can have a little bit of anesthesia just to take the edge off, and the test is pretty quick, maybe 15-20 minutes, a half hour to get the images that we need, and then the patients can go home same day. if the patient needs an intervention, meaning if we need to do something, we need to work on the blood vessels, we need to fix something, that kind of intervention, most often patients will go under anesthesia. We'll put them asleep so that we can really have good access and really good pictures and be able to control for many different variables and go in and fix whatever problems there are with the blood vessels of the brain. Usually an angiogram isn't the first line of a diagnostic test to look at the brain because it is invasive. We do go from the inside of the blood vessel with a catheter. So generally either a CAT scan or MRI may be the first line, but the gold standard, the thing that gives us the best imaging, the most precise imaging, the best resolution is an angiogram. So if patients get an MRI or they get a CAT scan and there's any question of something potentially abnormal, they often will need an angiogram to make the definitive diagnosis so that we know exactly what we're dealing with, and we have it in high resolution. We can have it from different angles, and we can have real-time blood flow velocity and pattern, both the blood flow in and out. On a CAT scan or an MRI, it's really just a snapshot image of the blood vessels. It doesn't give you the relationship of how quickly the blood's flowing in and out of different structures in the brain. Whereas an angiogram gives us terrific and the best resolution of the blood vessels, as well as the relationship of the blood flowing in and flowing out, so that we have that information as well. To do a diagnostic angiogram, when we either enter through the top of the leg or from the wrist, the catheter goes up and there's 4 blood vessels that supply your brain with blood. There's 2 in the front and there's 2 in the back. And we want to image each of those blood vessels from the front and from the side and in different angles. So we'll take the catheter and we'll leave it at the base of the neck, just at the beginning of that blood vessel, and we'll inject the dye, and the dye will flow up with the blood flow into the brain, and we'll take pictures. The dye flows through, and we'll go to each blood vessel individually, one at a time, and inject the dye and take the angles that we need and the magnification that we need to really learn about the blood flow and what's going on with that blood vessel. So we don't have to go inside of the brain when we're doing a diagnostic, but the catheter does go all the way up to the base of the neck. But because we live to the base of the neck, the patients don't have to be asleep. When we do any intervention, when we have to do some work to fix something in the blood vessels, that's when we put the patients all the way to sleep, just so there's no movement. It helps us get better imaging, and it also is easier for us to approach whatever that pathology is because we know we can control for a lot of different variables. So a couple of different aspects. When it comes to a ruptured aneurysm, typically what it is described is the worst headache of your life. You have the worst pain, the worst headache you've ever experienced in your life. Patients know something's wrong, and they will have their family or they will call 911 and get to the hospital emergently. They'll go for a CAT scan. We'll diagnose a ruptured aneurysm from the CAT scan, then bring them here to the Angio Suite to find out exactly where that aneurysm is, the size, the shape, its relationship with the blood vessels around, and thereby decide, can we treat here in the Angio Suite with coils from the inside of the blood vessel, or is it something that the patient needs to go to the operating room for an open craniotomy and clipping? So as far as ischemic strokes and their treatment, there's the acronym of FAST, which stands for face, arms, speech, and time. So face just means if you notice somebody with some facial asymmetry, one side's a little weak or a little off, or they just don't look normal, that could be an indication that something's going on and they may be having an ischemic stroke. Arms is if there's any weakness on one side of the body. Their arm is a little weaker, they are not walking right, maybe their legs a little weaker. So one side of the body being weaker than the other is abnormal. Should make you think immediately of a stroke. Speech, slurring of speech, difficulty finding words, difficulty forming words even though you understand, or difficulty understanding speech. Anything to do with speech that is abnormal for the person, that also could be indication for a stroke. And then the T in FAST is time. Time is brain. So if you think of any of those things are abnormal in yourself or in a loved one, it is 100% imperative. You call 911, you get yourself to the emergency room, and you get evaluated. The faster you do that, the safer it is for everyone involved. So when it comes to that particular procedure of performing a craniotomy and clipping of an aneurysm, there are virtually no words that can describe the feeling you get when you successfully clip an aneurysm in a patient. Essentially, you've taken care of a problem that could have ended that patient's life or devastated that patient's life. And you've gone from that moment before the clip goes on to any of those potentially terrible possibilities from happening. And as soon as you get the clip on and shut that aneurysm down and there's normal blood flow in all the branch vessels, you've cured that patient of that problem. There's no feeling like that in the world.